Hi, I'm just going to run you through a case study on a CF patient that we had at our hospital. He was a 24-year-old male that with cystic fibrosis. He also had a background of pancreatic insufficiency. I think he was actually homozygous to the F508 deletion. He had anxiety, he has ADHD, impaired glucose tolerance, and arthritis. The reason for referral, he was admitted for a tune-up due to being unwell and had a lung infection at the time, and he referred to the dietitian due to significant weight loss. He's now 47 kilos from a usual 56 kilos, which indicated a 13% loss of weight in the past 3 months. His height is 168 centimeters. His BMI is 16.6. And during our assessment, he had an obvious severe subcutaneous fat and muscle loss. The healthy weight range for a BMI of 20 to 25 would usually be in around 56 to 70 kilos, 70.5 kilos. He had a poor appetite and was struggling to eat. His diet history indicate he'd usually skip breakfast due to staying up late and sleeping in. He will usually eat at lunchtime around 50% of his usual intake, which is usually leftovers like meat and mashed potato. He was having about dinner and about which was a half a Subway or a burger, and he sometimes drinks chocolate milk, but not regularly. His diet history indicated he was meeting less than 40% of his energy requirements, and he was using nil nutrition support at present and not really using any food fortification techniques. He does not usually drink alcohol. Um, his lung function was his FEV1 was 33% at the time, which is indicating severe respiratory disease. Socially, he lives with his mother and has a brother who has an intellectual disability, and they come from a low socioeconomic status background. Assessment. So, in terms of nutrition diagnosis, after my assessment, I chose to go with severe malnutrition related to increased nutrition requirements for cystic fibrosis and inadequate energy and protein intake due to nutrition impact symptoms, which were poor appetite, shortness of breath, early satiety, and fatigue, as evidenced by diet history, indicating meeting less than 40% of requirements, significant weight loss of 13%, severe subcutaneous fat loss, muscle loss, and low BMI of 16. So another diagnosis you could have maybe used would be inadequate energy and protein intake related to increased nutrition requirements for CF and poor appetite due to nutrition impact symptoms as evidenced by diet history and weight loss. However, I think by using this diagnosis, we would have missed out on the fact that the severe malnutrition part of it, which is what will cause further lung disease and something that we would want to correct. Also, in the hospital setting, diagnosis of severe malnutrition will actually give the hospital back some more funding, and so it's good to be able to code for the coders for us to diagnose what level of malnutrition that it is. So that's why I went with that one. So in terms of assessment or diagnosis assessment, so a bit more on his background. His medications were he was taking Vita Abdec daily, usually pretty good with taking it. Sometimes forget, but mostly was adherent. He's usually on the Creon 25,000 enzymes. However, he wasn't really using a specific ratio. He would usually use, say, 3 Creon 25,000 if the meal was high in fat, and maybe 1 to 2 Creon if it was lower fat. He would use occasional Movicol if needed, but not routinely. Salt, he was adding salt to foods, but was on nil formal salt replacement. He was estimated to be getting around 2,000 milligrams per day, which was less than his requirements. Physical activity was minimal due to arthritis and pain associated with arthritis and shortness of breath, and of course lethargy. which I didn't put in there. His GI symptoms were sometimes constipation, especially with the use of endone, which he was using because of his pain. But sometimes he would have loose bowel motion due to missing his creon or maybe inadequate dose of creon with the meals that he was having. Biochemistry, the ward BGLs initially were between 5 to 7 millimoles. He did have one blood sugar level up to 10 millimoles post a soft drink, but otherwise was within normal range. His HbA1c in the past 3 years was between 6.3 and 6.9%. His fat-soluble vitamin levels were checked and they had been normal. His iron studies were normal. His estimated requirements using the Schofield equation and an activity factor of 1.4 and the CF stress factor, I just calculated a range there, which was 9,000 to up to 16,000 kilojoules per day. So the estimated protein requirements were around 79 to 141 grams per day, which is around 15% of his estimated requirements. And his salt requirements, like up to 6,000 milligrams, but potentially more. Our intervention. So nutrition support options were oral nutrition support versus enteral nutrition, plus a high energy, high protein diet and food fortification. So upon discussing the options with the patient, he was really struggling to have oral intake, and it was just mainly because of poor appetite and just disinterest in eating. And he was actually requesting to have a nasogastric tube inserted. So after liaising with the team, this was discussed, and an NGT was inserted. We commenced overnight feeds. So to do this, you would usually have to calculate the enzyme dose, and we started an initial 1 to 20 grams of fat initially, and then we thought we could actually down titrate the creon or increase the amount of creon needed if he was getting symptoms. The initial goal for overnight feeds was to get around a litre of the 2 cal per mil feed overnight. However, due to his significant malnutrition, he was deemed to be at risk of refeeding syndrome. And so a liaison with the team, we commenced IV thiamine, multivitamin, and we're checking his bloods daily. So we'd had to use gradual titration of the feeds. So we started nutrition concentrate at 30 mils per hour, which was just for nocturnal feeds at 12 hours overnight initially, and gradually increased each night by 10 to 15 mils per hour as tolerated. So over the days of monitoring, there was nil evidence of electrolyte abnormalities with slow titration, and the patient reported nil significant issues with the feeds or tolerance or anything like that. We continued to encourage oral diet. So in the hospital setting, we have a specific special CF diet, so they can actually order additional higher protein, high energy options at each meal. They get mid-meals, and they can order additional salt, as well as I ordered additional butter and things like that he could melt on top of his vegetables or meats or whatever it might be to boost caloric intake. We encouraged him to prioritize his protein, encourage regular meals and snacks as tolerated. And eventually, after he was out of that initial refeeding risk stage, encourage some oral nutrition support during the day if he was unable to eat much in terms of food intakes at mid-meals or meals. We also added salt to try and meet his requirements using gastrolyte sachets, and he was having 3 sachets a day, so 1 spread out morning, lunch and dinner. We also commenced some salt tablets and doing something similar, starting with one tablet um, 3 times a day. After the initial stage of titration of his nasogastric tube feeds, we, in discussion with the patient, explaining that it can take some time to get that weight restoration, we encouraged a peg, and patient was actually consenting. He wasn't really that keen on having the nasogastric tube. It was affecting every time he coughed, and it was a bit unpleasant, hurt when he was swallowing a little bit. So he was pretty keen to get the peg inserted for overnight feeds and for weight restoration. And it can also be used once he actually achieves that body weight. If he did have it and he got back to eating better again, we could actually have that peg as a backup for if he did have any acute exacerbation of his lung disease, or where he may have reduced intake and struggle to have oral intake again. He was also getting a workup for transplant, and usually the goal for transplant is to maintain a BMI of more than 17 to be accepted or listed onto the transplant. There's also another range of things that they would need to consider, but that's one of the targets, I guess, that the transplant team will be looking at. In terms of monitoring and evaluation, so initially the patient was reviewed daily in hospital for feed titration and monitoring of refeeding syndrome risk. Then we were monitoring every 2 or 3 days in hospital once stable or if clinically indicated. Once he was actually discharged home, the plan was to review monthly initially in CF clinic or via phone, and then once stable every 3 months. However, it can be difficult to achieve best practice in relation to monitoring. I know this patient was tricky once he did go home to get in contact with via phone, and sometimes we would not always attend the outpatient appointments. So monitoring was not always as best practice. But it's important to work with the patient and the resources that you have to try and get the best patient care. Other things to monitor were biochem, so initially refeeding syndrome risk, so making sure potassium, phosphate, magnesium, calcium, any of those electrolyte abnormalities were corrected. It was important to monitor weight changes. With the peg feeds, his weight was increasing gradually, and that was monitored. We then developed a goal with the patient to get to a target of at least back to 56 kilos, and then if we could get up to 60 kilos, that would be the long-term goal. We'd monitor nutrition impact symptoms and feed tolerance. There's lots of time spent educating with the patient on enteral nutrition, how it works in relation to nasogastric tube insertion, and the process of that versus peg insertion, which I think he actually had a radiologically inserted gastrostomy at the time due to his lung disease, not being appropriate for a general anaesthetic. There's lots of education spent with the patient and his mum, as well as the nursing staff regarding his home enteral nutrition, how to use the pump, Nutricia nurse involved in and linked in to the patient to perform pump education as well prior to discharge. A plan for the patient was provided. However, we had to modify this and write simple steps for the patient due to his learning difficulties to make sure he clearly understood what his feeding plan was for home, which was actually to continue with his oral intake during the day, so trying to aim for 3 meals and 3 snacks. as well as the overnight feeds of 1 litre, which was actually changed to isosource 2, as it had we could actually use a 1 litre bag versus having Nutrisyn concentrate only comes in 500 ml bags. And that way he could actually use 1 bag overnight without having to change the feed or get up and change bags or anything like that. So it's more likely to for him to continue adherence to the treatment plan of having the overnight feeds. So it is another burden that he has of care, I guess, for him to maintain his nutritional status. Now, the nutrition diagnosis may change depending on resolving of malnutrition with weight restoration. So that's another thing important to monitor and make sure that's documented. If there is improvements in weight gain, it might change from severe to mild to moderate or to mild malnutrition as we're correcting that with improved nutrition. Now, this patient also involved regular liaison with the dietitian at the Prince Charles, keeping them in the loop of his current plan as he was getting a workup to transplant, and providing a handover to the transplant team prior to their appointment. Key references and guidelines. So in this case, the guidelines that we used were the Australian New Zealand Nutrition Guidelines for CF, which are available online. Also local protocols, the enteral feeding protocols and refeeding syndrome guidelines. And I haven't mentioned there just post PEG insertion protocols followed as well. So usually after having a PEG insertion, it will be nil by mouth, and then we would start for nil by mouth, nil by PEG, for the first 4 hours. So making sure the patient's aware of that. And then we start usually 50 ml water flushes that are given hourly for each hour for the first 4 hours. If everything's okay in relation to his and with the PEG, then feeding can actually start after that. Post-PEG protocols followed as well. So the things to assess: oral intake, tolerance to feeds, weight changes, biochemistry, his bowels, and any medications. Interventions used: the diet modification, like high protein energy, increasing snacks, and food fortification techniques. Use of enteral nutrition. And then we added in some oral nutrition support, which he actually eventually, if he didn't feel like actually drinking the supplement, would do some boluses down his PEG as well, especially if he had no appetite to actually have a meal at that time. And these were all commenced as per the guidelines due to unable to provide adequate nutrition orally and a malnourished state. So we didn't want him to have worsening lung function in that. So regular liaison and engagement with the patient on his care is really important, and making adjustments accordingly. So every step of the way, making sure the patient was aware and involved in the decision making in relation to his care. The clinical case overview. So I guess the main points of this clinical case, I guess this patient we've followed for a good 12 months since. So I've just given you a general overview for the purposes of this case study. However, the main things are malnutrition. So our goal is to improve the patient's nutritional status from severe malnutrition. Hopefully this will improve lung function and his chance of survival and chances of able to get a lung transplant. So the use of enteral nutrition and monitoring of refeeding syndrome. So some learning in relation to that. Ensuring adequate enzymes. So use. So monitoring doses and symptoms to ensure adequate and to assist with weight gain. So obviously if we're adding all this nutrition in for the patient, in the way of overnight feeds and ensuring that we're adding using oral nutrition support or food fortification techniques, it's important to make sure that we're getting adequate enzymes and making sure he's being adherent to the enzymes, as he won't be absorbing any of the nutrition if we're not doing that adequately. So making sure that the patient is understanding of the importance of using his Creon, making sure he understands how to use it, and checking the timing and the way he's actually using it is really important. Ensuring adequate salt replacement. So that could have been a cause for why he's had a poor appetite. So making sure we're correcting that to rule that out as a potential cause of reduced intake. And the other thing to note is the enteral nutrition do have a low sodium content. So if we're replacing his requirements or his food intake, I guess, if he's not eating as much food but getting most of his energy requirements through having enteral nutrition or even supplements, they have not as much salt. So we need to make sure we fill the gaps to try and meet his salt requirements elsewhere through the use of salt tablets or gastrolite or glucolite. There are other options where you could add salt to water if they're not particularly liking gastrolite or glucolite. And the importance of close monitoring of weight symptoms to ensure achieving goals, engagement of the patient in his own care, and offering support and education where required. Thank you.